I think we'll get started. Thank you so much for being here. You had a great lunch. I know sessions just after lunch, they're not really the best time, but we'll just be able to talk about a very important and an interesting topic. So I want to welcome you to this session by the Global Fund in partnership with WHO on scaling up integration of HIV, TB, and malaria service delivery through health insurance schemes, early lesson from Global Fund pilots. Just without any further ado, I think we have our first speaker being Dr. Netila, Senior Manager, Health Finance Country Support for the Global Fund. She's going to provide opening remarks. Please put your hand together for Dr. Netila. Thank you.
Good afternoon, everyone. We are here for a very important topic, that is the integration of donor-funded programs, which are basically HIV, TB, and malaria, into the nation's health financing schemes in countries, which nowadays have taken exclusively the form of national health insurance funds of any sorts. So what we see in the region is that because the three diseases are funded in a very considerable way by international donors, the different national health insurance schemes and their related benefits packages usually leave the three diseases outside the benefits package under the assumption that these are being taken care elsewhere. Now, for us, this is a bit problematic for two reasons. Because first of all, having benefits package kind of formalizes the government commitment to its population on the services that the government will provide, regardless of who will pay. So if you leave the three diseases outside, you leave the people with these three diseases that also constitute a very big burden of disease. That's why the donors are there in the first place. So you leave them out the commitment of government to provide services for them, and you leave them in the hands of donors. And so that is not what we think a responsible government should do. So this is the first issue that we really focus on this issue. The second thing is that people living with HIV and TB, so HIV the most, then TB second place, and malaria is a little bit different. Because malaria is more or less part of primary healthcare, so malaria is much more integrated in service delivery, but also financing. These people, they have also other health conditions. So by providing them with ARVs, or with, in the case of TB, is much more related also with poverty. So by providing them with the medication and the services for their basic condition, we don't guarantee, first of all, their other health needs, and therefore also the outcome of the basic intervention for which we fund, because their health outcome will be conditioned also on their other medical conditions. So they get their ARV pills, but then if they have a cardiovascular disease, if they have diabetes, if they have a temperature, if they need surgery, they are uncovered as the rest of the population. Then there is also duplication in the system, because there are countries that if a person living with HIV goes to a health facility that has an insurance mechanism, because they have temperature, they say, oh no, but you are an HIV person, you have to go to your HIV program. And the HIV program, does not deal with as much as the HIV program can deal. So these are the two considerations. Now, having looked at it for quite some time, so we all agree, perhaps yes, it has to be part of the benefits packages. Therefore, that's why we have everybody here in the room, but there are some concerns. There is a concern, as I said, that if these programs are mainly funded by the international donors, then the government gets scared and says, yes, but I can't take over these programs overnight. So we need to find all those modalities, first of all, to have kind of sensibility to the government. The fact that they put it in a benefits package does not mean that the government will start to pay for it, because, you know, for as long as donors are there, they will try to pay for it. So this is number one. And then number two, it is to kind of push donors like the Global Fund that I represent also to start investing in these schemes. And so that's why we started with these 3 pilots. But then, and the last consideration is that for us to start investing in these schemes, there are 2 issues. First issue is that there have to be the fiduciary and the public financial management systems in place that make sure and that tell us that the money is also following populations of our concern. And secondly, because the 3 diseases have programs that have been funded by donors, and this constitute a large burden of disease, and the insurance schemes, they are very nascent. So what happens is that the programs funded by donors, they have a much more population coverage than the nascent insurances have in countries. So we have these countries where you have an HIV treatment program that covers 80% of population, 85% of population if you include government and the different donors, but then you might have an insurance that covers 7% of the population. So there are issues there, and this is not something that can be done overnight, but it is some place where we need to start. And that's why, and you will hear from our colleagues that will set the stage, but also from our country representatives, you will hear on how we are gradually going into these schemes. And the first thing that we said, given that the 3 countries have a considerable burden of disease, we said, okay, given that we do have some health system strengthening funds, we will enroll people living with HIV and people living with TB, especially in the hotspots, even if the benefits package do not include any services for HIV or any services for TB. Because we do it for 2 reasons. We do it, the first reason, to give these people protection for their other health conditions that they might have, but also to give a boost to the insurance so that the number of enrollees increases, and so then the schemes become viable. So this is a little bit the approach that we have taken, and I will not take more time than this. I will let my colleagues to set the scene, and then the countries to tell us their stories and their operational steps on how they are starting with the implementation, identification of the beneficiaries, and then we can discuss a little bit better of what this will mean for the Global Fund.
Thank you. Thank you so much, Dr. Netila. I think I made a mistake in the beginning. I did not introduce myself. My name is Sophie Fay, and I work for WHO-AFRO, based in Brazzaville. So now we'll just have 2 colleagues come up here and set the scene. So these are Mr. Kingsley Frimpong, technical officer with WHO Ethiopia, and Mrs. Regina Ofei, specialist health finance with the Global Fund. Kingsley and Regina, here's the mic.
Thank you very much. Good afternoon, colleagues. Just a few minutes, we'll just project our presentation. Is that the final one? So in the spirit of collaboration, our agenda setting the scene is demonstrating that WHO is working with the Global Fund on this one. All right. So I think almost every country is working towards the UAC agenda. And given that, oh, I have to. All right. So almost every country is working towards the UHC agenda. And so country priorities are really working towards that. Now, one big challenge has to do with the structure of the market, the formality and the informality in terms of those that we are supposed to serve. It is important for you to know that when you talk about health financing, the UHC goals is actually influencing our health financing objectives in countries. Right. So member states are exploring responses to the challenges of informality, which is really a critical thing. Now, as WHO, I think the focus for us is really to look at progress towards UHC goals and not merely participation in a scheme. But it is important for you to know that this section is really looking at a particular scheme, national health insurance. How do we integrate HIV, TB, and malaria into national health insurance schemes? So it is important for us to ask ourselves three main questions, right? The first one is, how can we reduce barriers to effective service use? That's the very first question. The second question we ask ourselves working with member states is really, how do we improve financial protection? And then how do we prioritize the poor and the otherwise vulnerable people while setting foundations and dynamics towards universality? Now, sustainable HIV, TB, malaria is reliant on three things. The first one is really looking at a health system that ensures all these characteristics: adequacy, sustainability, predictability, efficiency, equity, transparency, and accountability. And once you're able to establish this, we work through the health financing functions. And the point I really want to make here is that as program managers for HIV, program managers for malaria and TB, it is important for us to also focus on the health financing function. Sometimes we limit ourselves in the service delivery without looking at the health financing functions. You have to be there when they are discussing revenue mobilization issues. You have to be there when we are talking about pooling, and you have to be there when we are making purchasing decisions relative to service delivery, which is dependent on effective PFM systems. And it's important for us to understand as program managers of these three, understand the budget cycles, the budget formulation process, the budget formulation, budget execution, and then of course, in terms of reporting and so on and so forth. Now, the issue of integrating these three programs into national health insurance scheme is really speaking to two major issues looking at the relative to the health financing functions. The very first one has to do with the pooling, right? And then the second one will talk about developing benefit, designing benefit packages. So if you look at what we have here in this diagram, the pooling is really geared towards, sorry. It's not moving. It's not moving. Sorry, just 1 minute. Is it from this one? Yeah, that's this one. Yeah. Oh, because you're sharing it. But it's still showing.
I think it's this one.
I have two of them popping up.
Another one.
Another one. Okay. This one. Okay.
This one.
No, not this one.
see.
Sorry, we have so many of them open up. Can you show me which one? It looks like so many of them open up.
Yeah.
Yeah,
Close to
they've closed all of them.
Oh. Second. It's fine.
This hybrid thing is a problem. I
Yeah,
think
sometime.
I saw setting the scene there. Just open it, yeah. The internet, yeah.
You have the hard drive, flash drive. You can show it to me. I can do it for you.
I sent all of them to the organizers this morning.
So you should have it.
They say you are the one to slide it for yourself. That's why.
Sorry, we have a bit of a technical issue. The internet just stopped working, so.
Doing two projects for you.
Program, okay. Yeah, I've stopped sharing. I mean, yeah. Shall we go ahead? Okay. All right. Thank you very much for your patience and apologies for the technical hitch-up. Yeah, so as I was saying, the topic of integrating the three programs into health insurance is also speaking to the issue of pooling and the issue of benefit design. So in terms of the pooling, we are pretty much, and if you look at the earlier slide that I presented, we're looking at how do we use pooling policies to look at financial protection, equity in service. And in terms of the principles for pooling, the idea is to maximize potential to cross-subsidization. So the cross-subsidization capability is really important anytime we introduce pooling into your mechanisms. And of course, contribution should be independent of the health risk, right? And so it is important for us to look at this whole topic from that broader perspective of pooling within the health financing function. Next. All right. Now, in terms of attributes, over the years as WHO, we've actually gathered experience through literature, and we've come out with two main attributes of pooling arrangements. One, large size in terms of the number of people covered by the pool. So you have the young supporting the old, the sick supporting the healthy, and so on and so forth within the pool. And it's important for us to look at that. And then, of course, diversity of health risk within the pool is also important. Next. Right. Again, in terms of pooling, we've been able to identify close to 8 different ways of pooling. If you look at the topic for today, we are basically looking at single national pool with compulsory or automatic coverage. And of course, you can get so many others relating to pooling. And again, it's determined by countries, member states. We are not going to go through all of this, but the critical point here is that in as much as we are speaking to the single pool, we have many others that you can design. Next. All right. Now, the second issue, again, relative to integration of the 3 programs, has to do with health benefits design. And here we are saying that we need to look at it from a system-wide approach about how all the public funds are used to provide benefits, whether explicitly defined in a package or not. We also need to focus on the benefit design. And this is important. We need to focus on benefit design rather than benefit package, because the moment the focus is on package, you are limiting yourself to the broader needs of the population within the setting. And then, of course, you prevent a narrow focus on health benefit package, which often serve as a very small part of the population, leaving no one behind. The UAC has a 3-component, and coverage is important, access important, financial protection is important. So as policymakers, let's focus on the co-payment design. The moment you're talking about benefit package, then there's a component of co-payment. It has to be part of your benefit, your design, the benefit design. Even if it's not part of the package, it has to be included in your design so that you can take care of it in terms of those who are not captured in the pool. Next. All right. In terms of benefit design, again, we've gathered information, we've gathered data in terms of attributes. If you want to look at a benefit design, what are some of the attributes? Next. First, the entitlement and obligations must be clearly understood by the population. Everyone within the setting should know what he's entitled to. So he's speaking to the issue of entitlement. It is also working towards a unified framework within which a set of priority health service entitlement is implemented for the entire population and not just selected few. Another attribute is that the service benefit changes are subject to cost effectiveness and budgetary impact assessment, because whatever is available in terms of fiscal space is what the benefit package can accommodate. And of course, defined benefits are aligned with available resources, the health needs within the population, and then the mechanisms to allocate funds to the providers. And that's why earlier on, I was actually focusing on the need for program managers not to focus their attention on service delivery, but also looking at the entire health financing functions. And finally, benefit design includes explicit limits on user changes and protect access for vulnerable groups. Next, this guy is not paying attention. All right. So at this point, I will hand over to my colleague, Reggie.
Thanks, Kingsley, and apologies again for the technical hiccup. We're trying to resolve it for the next session, the next presentation. So as Kingsley said, trying to set the scene for what it means to really integrate HIV, TB, malaria services, and what it means as a second consideration to extend coverage to these populations. A systematic review that was conducted by a team from the London School showed that a lot of the literature actually on what it means to extend coverage in the region remains very sparse. There's really no documentation on what schemes have done to consider informality, and more specifically to our conversation today, consider populations living below the poverty line and with some key conditions such as living with HIV or in TB hotspots. So what we have seen in the literature is that even when targeting in our region has been considered, it has been for children, for women, for the elderly, for, of course, low-income populations, rural populations, and people with some chronic conditions. But we didn't see anything specifically in the literature that was looking at really considering how we start to merge some of these larger programs with, in some contexts, larger financial purses than the insurance schemes into the insurance schemes, which we know is the way to go if we are aiming to integrate services and scale up service coverage towards universal health coverage. Next. So trying to synthesize what we saw in the literature, this is quite incomplete because, as we said, there's quite a dearth of evidence out there in terms of targeting. But some of the things that came from the systematic review and from other literature that we searched was, some of the mechanisms that have been explored, including, using legislative instruments to target these populations. So what is the question? Do we lower the premium for these people to make sure that they can afford to pay? And our colleagues from the countries will tell us some of the interventions that they have deployed in their schemes, linked to some of the documentation that we have tried to synthesize here. The second consideration is really an access consideration. Sometimes in these informal sectors, actual contribution is not the problem, but access to enrollment is the problem. So going into the communities and enrolling people at that level is another consideration for targeting. The third is around adjusting the premiums, so using subsidies or setting proper premium levels for different pockets of the population so that we don't have a cross-cutting amount that we expect people to pay regardless of their means to pay. It's another thing that came quite strongly from the systematic review. And then, of course, innovation, which is where I think a lot of the work that we're doing for this pilot comes to play. So what role does external donor assistance have to play in extending coverage? As Netila said, it's obviously not a long-term solution, but thinking through what it means to invest in these schemes, to contribute towards extending coverage through premium payments is one thing that can be classified as innovation. In some contexts, we also have countries setting up separate equity accounts or funds for these vulnerable groups where donors can contribute, governments can contribute, and the resources that are pulled through that are then used to purchase services for the target populations that we are talking about today. The last thing around innovation is something that I covered in the first one around the sliding scale premium. So how do you actually use actuarial analysis and data to set up the premium payments or the premium contribution setting in a way that is affordable to all, regardless of which pockets of the population you belong to? And then the last is integration with other social safety net programs. So health insurance schemes, as we know, are a social safety net program of some sort. Of course, they provide social protection to these populations at hand. But in several of our countries, we have other interventions for social protection, and they they consistently or often cover a lot of the same populations that we aim to cover with pilots like the one we are discussing today. So what does it mean to tap into those databases, use the targeting mechanisms that are already existing for these programs to then extend to health insurance targeting? So we are not reinventing the wheel, we are considering efficiencies, and we are also making sure that what's working works for the entire social sector and not only for health or not only for education and so on and so forth. So, great, thank you. So the challenge is, there's a lot of heterogeneity when we talk of informality. We have people who are in the informal sector but can pay. And of course, the fact that you can pay is not the only mechanism or the only consideration when we talk of insurance. There's a lot of fluctuation in income when it comes to informality. And we also have other considerations such as the fact that we are not then able to properly target using informality as the only consideration when we launch these pilots. So a lot more data collection, a lot more tracking of people's social means is important to make sure that we actually cover and reach the people who are most in need of these interventions and this financial support coming either from governments or from external donors like the Global Fund. Next slide. So what did the Global Fund do in Grant Cycle 7? So Grant Cycle 7 is the current cycle we are in now, and it's from 2023 to 2026. And this grant cycle is anchored under the Global Fund's strategy going from 2023 to 2028. And the strategy, for the first time ever, has the goal of building resilient and sustainable health systems at its core. So we are moving away from the narrative of vertical programs to thinking through what it means for a fund that is targeted at HIV, TB, and malaria to invest more systematically in health systems. So as part of our operationalization of the strategy, we came up with a health financing module which covers a suite of interventions, but at the core of these interventions are the financial protection interventions that we'll hear about today. So we put this intervention in what we call a modular framework to allow countries doing their application to Global Fund grants to actually apply for grants to extend coverage to people living with HIV, TB, and malaria who are also considered indigent. So a couple of countries submitted proposals as part of their funding requests. We have today Nigeria, Zambia, and Cote d'Ivoire, who are really the trailblazers in this space. And of course, Rwanda, who was even doing this before we had a health financing module in our modular framework. So with the modular framework, just previous slide here. With the modular framework, we are now able to systematically invest in insurance schemes, and we are also able to really have health financing systematically support countries to scale up financial protection mechanisms. Next slide. So how do we do this? We have a broad health financing strategy for our department or at the Global Fund, but this work really sits within Stream 3, which is technical support to countries, where we have health insurance pilots, and we are also scaling up efforts to support governments with the development of their national health financing strategies, strengthening analytics for resource tracking in health financing, public financial management, amongst other things. And unless I forget, also a lot of work on domestic financing advocacy to make sure that governments are taking up more in the spirit of sustainability. So that's really trying to situate or bring together all the work we're doing. This is how it sits within our day-to-day work at the Global Fund. Next slide. So I won't spend too much time here because we have the colleagues who are really leading the work in the front lines and in leading the work from government side here today with us to talk about their experiences with the pilots and what they have done so far. We have a $10 million pilot in Nigeria this cycle, a $1.5 million pilot in Zambia, and about a $1 million pilot in Cote d'Ivoire. Blending the Cote d'Ivoire pilot is unique because it's blended with a broader World Bank project, and there is a specific disbursement-linked indicator to this piece of work. Next slide. And at the core of all of this is the need for data. So we've also built in, beyond the money that is being provided for premium payments and extending coverage, we have built in some amounts of money to really strengthen data. So we are hoping that in all the 3 pilots, we'll have some sort of data evidence generated, which will be used to scale up evidence in this cycle so that more countries can see the value of this work, the real impacts that's coming out of it, and consider also adopting this in their funding requests for the next cycle. And I've put really a high-level summary of the kind of things that we're doing in terms of evaluations, monitoring and evaluation, and I'm sure the colleagues will speak to this more. But for the Nigeria pilots, we are soon launching an evaluation, both process and impact related, to see what will come out or what we really will achieve with this pilot in Grant Cycle 7. And the idea is that if it's proven to be successful, we can advocate internally and externally for the use of this mechanism to really advocate for integrated service delivery and universal health coverage as a whole. So I'll stop here. This is sort of the scope of the discussions that our colleagues will take us through today. It promises to be a very enlightening and eye-opening discussion, and I hope we'll all learn something today and also use it as a mechanism to start to advocate for the importance of integration going forward. Thank you.
Thank you so much, Regina and Kingsley. I think that setting the scene was very enlightening. I heard sustainable financing, which you can only achieve when you go through the system that the government have, including national health insurance. I also heard the importance of integration. And also, I think this is a model of partner collaboration. So we'll hear more about this work, and we'll start with colleagues from Nigeria. So please, let's welcome Dr. Kofi Abubakar. Thank you.
Thank you very much, and good afternoon, all. Please just put it. Yeah, okay. Yeah, sure. That's fine. So you'll just be changing for me, right? So thank you very much for the foundation laying as far as the progress in the implementation of the Global Fund grant. And for us in Nigeria, this is a formative stage. So I will just be sharing with us early lessons as far as the grant is concerned. So this is the outline of our presentation. We will talk just to give an idea of the burden of malaria, TB, and HIV in Nigeria. We'll narrow it to the strategic focus of the National Health Insurance Authority. And then I should give it to you. You are touching it. You just be changing for me, please, if that's a problem. Sorry about that, please. Okay, next slide. Okay, next slide. Okay, so this just gives an overview of the burden of TB, HIV in Nigeria. And we all are aware that about 1.9 million Nigerians are living with HIV. And in terms of statistics, the country with the second highest cases in Sub-Saharan Africa. TB cases also are about 440,000 TB cases are recorded annually in Nigeria, making it the highest in Africa and 6th globally. We contribute 27% in number of global malaria cases and 24% malaria deaths, over 100,000 new HIV cases annually. So this brings to fore the importance of this disease as far as the country is concerned, and the need for us to be innovative and deliberate in tackling this menace. Next slide. Next slide, please. This also just to further highlight, just to further highlight the importance of TB, HIV in the country, and to also show that apart from the non-communicable diseases like TB, HIV are beginning to take, the stage in contributing immensely to the premature deaths in the country. Next slide, please. The picture is not really that bad. Progress is being made, and I'm trying to here with this slides try to show the some efforts that have been made to change the narratives. We can see, for example, a gradual a decrease in the new number of new HIV cases. The prevalence of HIV/AIDS in the country is also going down. And of course, TB incidence rates in the country is also reducing. So Nigeria has really experienced a significant progress in 2023, recording the lowest TB incidence rate over the 3-year period. Similarly, HIV prevalence has declined from 5.8% to about 1.4% in 2020. Percentage of HIV-exposed infants with negative outcome is also reducing. And then despite this positive trend, continued efforts are essential to sustain progress, particularly in high-burden areas, to reduce these new infections. Next slide. This is also to build on the discussions this morning on the low coverage with health insurance. This is the actual coverage of health insurance in Nigeria as at Q4 of 2024. We have 19,216,888 Nigerians with health insurance. Sorry, please. Okay. The blue line here is the target that we have set for ourselves as a country to achieve 20,156,941 by 2027. The progress, of course, is very rapid, and we're happy to say that we're already overshot our 2024 target, which was 17,667,324. A lot of innovations are driving this, and also deliberate reforms that I will show have contributed to this. But the most important is that first of all, the deliberate efforts to really consolidate the centralized health insurance system in the country, and also provide that universal leadership to coordinate all efforts in the health insurance ecosystem to ensure that this trajectory is maintained. So we have sustained this growth, and we have enrolled additional 2.4 million Nigerians in 2024. A growth rate of 14.4%. This is the highest ever growth in health insurance in 1 year in the country. We have also launched actuarial studies to determine and integrate the cost of HIV and TB alongside other services into the health insurance. This was a huge data gap when we came in. So really, how do we know how much it costs? And so this will guide us to ensure that when we are including HIV and TB services into the health insurance, we are working with evidence. However, health insurance benefit package does not cover TB services. Completely TB is excluded. And for HIV, only screening is covered in the benefit package. So I think this is now building on what was said this afternoon, is that there is need to really include these services into the package. Huge gap in coverage for the poor and vulnerable in the health insurance pool. The informal sector, the poor informal sector, is really up to now the large pool that we're trying to mop up into this number. And then, so there is need for deliberate policy targeting of priority conditions like HIV and TB to be able to bridge in this gap for the poor and vulnerable to have access to health insurance. Next slide. Next slide, please. Sorry about that.
Apologies, we are working through some technical challenges. Hopefully, we'll be back online soon. Thank you. Yeah, I was gonna say, can we just project indoor? On the Q&A, but thank you so much for sharing the Nigeria experience. Before we welcome our next presenter, I wanted to apologize because earlier with the network issue we had to disconnect the Zoom. So some of you listening into the translation, maybe you're not hearing anything anymore. That might be the reason. Sorry about that, but the internet was just not being very stable. So let's continue. I think next we'll call our presenter from Zambia, Mr. Herriman Mono. He's Director of Research and Planning at the National Health Insurance Management Authority. Let's welcome him, please. Thank you.
Thank you so much, and we're delighted to be here to share our experience of implementing the Global Fund supported pilot project, which is extending coverage of the National Health Insurance Scheme to the poor and vulnerable, and integrating HIV, TB, and malaria services in our National Health Insurance Scheme. So this is the outline. I'll just briefly tell you about our scheme, the National Health Insurance Scheme, the key highlights of the benefit package, and the overview of the Global Fund pilot project, what we have seen so far in year one of implementation, and what we think is the future of our scheme in HIV service provision. Next. So briefly, our scheme is one of the newest schemes on the continent. It was born in 2018 through an act of parliament and began implementation in 2019. So Act number 2 of 2018 created the scheme as a mandatory health insurance scheme to provide for sound financing for the health system by augmenting the general tax revenue that is predominantly the source of financing. And within that model, we want to achieve 5 key things. The first is that we will provide financial risk protection against catastrophic and impoverishing health expenditures that individuals and households might be exposed to due to illness. And here we're looking at the demand side of healthcare, individuals and households. And secondly is really to ensure the availability of funds in the health system. That is, ensure that the healthcare system has the resources it needs to provide healthcare services. This is looking at the supply side of healthcare. And the third one is to enhance equity and access. And of course, equity is one of the key objectives in UHC, that every individual access the healthcare services they need. And of course, through that objective around equity, the structure is that you contribute based on your ability to pay, but you access services on your need. So there's no risk weighting with regards to contributions. And fourthly, of course, is to harness the private sector participation in service provision. So here, looking at the service provision expansion, to the entire population. And number 5, which is critical, and that's why we're here, is really that this becomes a vehicle for achieving universal health coverage, that people access the services they need without suffering any form of impoverishment. Next slide. So we have the scheme, the National Health Insurance Scheme, and then you have the authority, which is where I come from, the National Health Insurance Management Authority, which basically implements the authority. And the pilot project, of course, is being run by the authority itself. And our role is to manage the National Health Insurance Scheme and advise the Minister of Health on health insurance policy formulation, to manage the Health Insurance Fund, from which we procure services on behalf of the population. So as a fund, we collect contributions from individuals registered on the scheme, and from there we procure healthcare services on behalf of the population. So strategic purchasing is one of our key roles. And in order to do that, of course, we have to accredit healthcare providers where our members will access these services, and the services that they access is defined in the scheme benefit package. And of course, as I mentioned earlier, the benefit package we have is standardized. There's no differentiation. So everyone accesses the same benefit package irrespective of the level of contribution they have made. And then, of course, we ensure that the members that access services are registered. So only those that are registered and are contributing will access our services on the scheme. So briefly, this is how we implement the scheme. So the implementation arrangement here, you have NEMA there, the National Health Insurance Management Authority, which receives premium contributions from the registered members into the National Health Insurance Fund. The fund procures services from the accredited healthcare providers, and the services, of course, are the ones that are accessed by our members. So between the members registered on the scheme and the healthcare provider, there is no exchange of financing. It's 100% coverage. So all services are paid for by the scheme. So they access services in a cashless manner. We are invoiced by the healthcare provider and we pay for those services. But of course, our services are mostly curative level services, right? If you look at our levels of care, level 1, primary health care, level 2, level 3 are the curative level of care. The scheme kicks in at the curative level of care. So starting from the hospitals going upwards. Primary health care is, of course, supported through general tax revenue by the Ministry of Health. Next slide. So what do we provide in our benefit package? This is the benefit package of our scheme, probably the most generous benefit package you will see in the world for the level of contributions we have. So currently our contributions are based on 2% of basic income, split between 1% employer, 1% employee, 2% of basic income. And for that, you access all these services without limitation. So you can pay $2.5 a month and you access a kidney transplant that we will pay for, $2.5 a month. So really one of the most generous benefits packages we have, from medical care, consultations, examinations, diagnostics, including radiology and laboratory and nursing care, surgery, including kidney transplants, and all such services, maternal and neonatal care, really the entire continuum of care around reproductive and child health, eye care services, oral health services, pharmaceutical drugs and supplies, everything that you can think of as approved by the Ministry of Health's National Drugs Formulary. But, of course, here we exclude ART and TB drugs. Then, of course, physiotherapy and all other selected services. So as you will see, we pretty much cover everything apart from just 2 key drugs, ART and TB drugs. But everything else is fully covered by our scheme. Next slide. So obviously our 3 conditions of interest are covered on the scheme. If you look at HIV in terms of the tests and also the management of HIV itself, such as CD4 count, CD8 count, all those are fully covered by the scheme. Viral load analysis, PCR, all those are fully covered by the scheme. So from testing to HIV management, fully covered, apart from the drugs. So it's only the drugs component that is not covered there. If you look at malaria, 100%. Everything is covered apart from the prevention side, such as insecticide-treated nets and all that. But once one has malaria, everything is fully covered. All the anti-malarials as approved by the Ministry of Health. TB, we pretty much cover a lot, but we don't cover TB tests on the benefit package. However, when one has TB, apart from the drugs, we cover everything else they might need, including liver function tests, which are critical services that one who is on TB is required to undergo. So that is really what our benefit package looks like. So if you think about it, we are already integrated in terms of the 3 conditions on HIV, malaria, and TB. The only missing part is the preventive services, which, as we imagine from our scheme, that is primary health care, which is not a priority, and then the drugs around TB and HIV. Next slide. So, given that background, of course, we then got the support from the Global Fund to pilot this exercise where we extend coverage of the scheme to the poor and vulnerable populations who have no contributory capacity, right? So the National Health Insurance Scheme and the law is very clear. The poor and vulnerable population are exempt from contributions. But someone, of course, has to cover their contributions onto the scheme, otherwise the scheme would be insolvent, right? So we reached out, of course, with the Ministry of Health to the Global Fund to pilot the idea of bringing the poor and vulnerable population who are on ART, TB, or live in high TB areas and other conditions onto the scheme, and to check, one, the potential sustainability of such an undertaking given the levels of contribution, and importantly for those on ART, to look at what other services do they need beyond ART. Because of course it's not enough, and we have seen, just to be on ART treatment, there are other services that are required. Now if you're poor and vulnerable and are on ART, who is covering for those other services? So you realize you're on ART, but you're still exposed to financial hardship as a result of illness. So we received the $1.5 million grant, and the idea is that we target households and individuals under what we call the Social Cash Transfer Program. So this is a program by the government which is targeting the poor and vulnerable across the country, and they receive a monthly living grant of about $40 a month. So each household receives about $40 a month, from which they buy food, sometimes before government policy changed, pay school fees, and including access to healthcare services, $40 a month. Now, obviously, that's not enough given the cost of healthcare. So the grant is, the pilot is such that we pay for premiums of these households. And the target is a household rather than an individual. And the reason for that is you want to provide financial protection for the entire household rather than just that one person who has a particular condition. So 16,000 households across high TB districts and across high HIV prevalent districts. And the whole idea is that, of course, once these people are brought on board, you enhance access to healthcare services, thereby improving health-seeking behavior and increase financial risk protection for the poor and vulnerable. We think for us, if you cover the healthcare costs, the value of their social cash transfer will actually significantly improve because they will no longer have to pay for healthcare because that has been taken care of. And I think that will have a positive dent on poverty reduction. And then, of course, we reduce inequality in access because they will access services that everyone else accesses, irrespective of who is actually contributing for them. And then, of course, we think we'll be able to generate very robust evidence on the sustainability of the scheme, given the level of contribution parameters we have put in place. Next. So the rationale, of course, like I mentioned, is to provide financial risk protection to the poor and vulnerable households that are at risk of being left behind, because they have no contributory capacity. But you realize they're the most in need. So we think this is perhaps to UHC, should be the first mile rather than the last mile to UHC. But right now we have brought in everyone who is able to contribute. But those who are unable to contribute have been left behind. And when you have 60% of poverty in a country, really you should be targeting at the 60%. And these are the people we're targeting here. So the social cash transfer program has 5 inclusion criteria. It's looking at households with elderly persons, 65 and above. You're looking at households with a member with severe disability. You're looking at a household with a member or members who are chronically ill and on palliative care. You look at child-headed households below the age of 19 and female-headed households keeping at least 3 children under the age of 19. Now, when you look at these people, 1, they have no income. 2, they rely on government, but they also have the most healthcare needs. So who pays for them if they're not part of the scheme? That's where the intervention actually comes in. Now, imagine these people on AD and these people on TB treatment. So their needs are even higher, and that's where the pilot comes in. Next slide. So what are the key interventions? The first, of course, the key one is to pay for the premiums that have been identified as the due rate. At the time of submitting the proposal, we estimated that $2.5 per household per month would potentially cover the required premiums for the households. And that's what was given to us that time when we submitted our proposal. And this was determined by an actuarial evaluation that was done with the support of the ILO. And once the contributions are paid, of course, we bring the onboarding of these people. So we do the actual registration, we go to their communities, sensitize them on the benefits of the scheme, the benefit package, where they access services, grievance mechanisms, and all those. And then, of course, public awareness campaigns. We're using this also as a vehicle for awareness campaigns around the extension of coverage to the informal sector. So those that have the capacity to pay, we're pushing that agenda through this pilot. Next. So what we hope to achieve, again, obviously, financial risk protection. Importantly, provide linkage for persons who are on HIV, on TB treatment, to the NEMA comprehensive benefit package, those that would not otherwise be on the scheme. Enhance access to healthcare services, and we think we're creating an impetus for additional health system financing reforms that will enhance the quality of healthcare services between the in the population, in bringing in, of course, the private sector and enhancing equity in access. And through this process, we think we can catalyze government commitment to actually supporting the poor and vulnerable onto the scheme. Next slide. So what is the implementation arrangement? We have our pilot project beneficiaries that are registered onto our scheme. They access healthcare services through our registered healthcare providers. And of course, we pay premiums from the Global Fund. So what the Global Fund pays are not the actual service costs. It's the premiums that our members, that members pay that go into our National Health Insurance Fund, from which we pay the value of the services. And then, of course, these members will access services in both the public and the private sector without any discrimination. Next. So, what was the criteria for selection of sites and the inclusion criteria? Obviously, you have to look at regional distribution, look at urban and rural areas. At the household level, we're looking at first vulnerability, because we're looking at the poor and vulnerable, so you have to be vulnerable, meaning that you have to be on the social cash transfer register. And luckily, we have a comprehensive integrated social cash transfer system, which is run by the Ministry of Community Development and Social Services. So we rely on the register that has already been created. And then we check how many of these are on AD, how many of these are on TB treatment, and of course, disability is one inclusion criteria, but disabled persons in high TB districts, that's the criteria. Then, of course, using that criteria, we came up with these sites. You have Lusaka Province, Central Province, Kobe Province, and Northwestern Province of Zambia. Okay. Now, to inform the actual selection, so what we did was we mapped the distribution of AD, against the distribution of social cash transfer households. And where you have the highest correlation was our initial selection criteria. So most of the districts that you're seeing are the districts and provinces with the highest correlation between being on ART and being on the social cash transfer program. So that way, you're really targeting at the ones in need the most. Okay, so we did the targeting, then we went out to do the actual registration. And these were the results that we picked up. So the target was 16,000 households. We reached our target of 16,000 households in November last year, starting the registration around June. By November, we had reached our target of 16,000 households. And that is the distribution of the households by category: disability, HIV, and other chronic conditions that were brought in. Now, what you realize is actually disability has a high proportion of all the members, followed by HIV and what we call other chronic condition. There's a reason for that. So HIV, as you saw, is not a criteria for inclusion on the social cash transfer program. It's not a primary criteria. But disability and other chronic conditions are a criteria. So for us to be able to actually get and tease out the HIV numbers, we had to get the register from the social cash transfer and match that with the ART registers in the Ministry of Health. Now, for that to happen, you need a unique identifier so that you can check who is on both registers. Now, we faced a bit of challenges there in that the unique identifier we use as a country is a national registration card, which is not mandatory for one to register on ART. So there are a lot of omissions that we know are there. But what we are now seeing actually with the people on disability and other chronic conditions, they are also on ART. So once we did the registration, we made follow-ups, and you realize we actually have disability and HIV, quite a number of it. And so we're beginning to do the realignment that only those on, regardless of whether you're you are disabled or not, if you're on ART, we want to put you exclusively on ART. But we're also thinking we can split that a little bit further because the needs may not be homogeneous, right? So you're disabled and on ART, so your needs might be different from one who is not disabled and on ART. So we're trying to do further disaggregation in this year. But luckily, we have all the target households registered as of November last year. And this is just explaining what I just said, that because being on ART is not a criteria, it's difficult to actually isolate that without matching the registers with the Ministry of Health. And so this year, we're focusing on ensuring that we tease out those who are on ART, irrespective of whether they're disabled or not. But also, I think, like I mentioned, we want to see the heterogeneity in demand given the different categories that we have. Next slide. So, how is the fund performing? So effectively, what we have done here is to create a fund within the fund first. So within the Global Fund, within the National Health Insurance Fund, you have the Global Fund, right? And so we are saying, let's check the sustainability of the Global Fund within itself first before we cross-subsidize with the main fund, right? So what I'm showing you here are the results of the premiums paid, and premiums are only paid when people are registered. So you only pay for the people that you have registered. And then the utilization over time. So what we see at the end of last year, December 31st, utilization was at about 85% of the total premiums collected. So it's still holding. And the latest results we have actually at full scale, at full load of 16,000 households, utilization is coming down, which is very interesting for us. So you saw a spike, you see a spike in utilization. For us, that's responding to unmet need for healthcare services. So suddenly they can access healthcare services. They go to the facilities and they access the services they need. And beyond that, obviously, we hope that their health status is improving over time, and so the use is not that high. So right now, the fund is holding. We're not cross-subsidizing into the main fund yet. And I think once we allow it to mature for a year, we'll be able to tell, can the $2.5 per household per month hold? If it can hold for this segment of the population, then certainly you can extrapolate that to the entire population as a minimum that can keep the scheme solvent for the benefit package that we have. Next slide. So we have created a real-time monitoring dashboard. So all the registered members, because of the nature of our scheme, we use biometrics. So once you're registered, the unique identifier are biometric. So when you go to a health facility, it's biometric. So in real time, we're able to check who has accessed what service and where. We're able to track that in real time. So every day we get reports on the utilization by member. So this is our dashboard that we have created specifically for the pilot project, which working in line, side by side our main dashboard. So our target household target, 16,000 was achieved. Now, each household can register beneficiaries under them. So though we have 16,000 households, the total number of people actually registered under the pilot is 42,850. 42,850 registered and accessing services under the pilot project. And then, of course, that's a distribution which I shared with you earlier, and that's a distribution by district and what has been consumed thus far. So the number of claims you have there and the value of the claims, which, like I said, we track in real time. And then we're also able to track what are the top 10 conditions that the members are utilizing the most to give us the evidence to really justify our pilot. Then, of course, the age gender distribution, 68% female and then 32% male. Again, this is reflecting the distribution in the social cash transfer household. We have more females than males as principal beneficiaries under the social cash transfer program. Next. Okay, so we say to ourselves, now that we have this evidence, we have had 3 months of full registration as of November, can we assess the distribution of utilization of services? What services are being utilized the most by our members? And this is what you get. Interestingly, laboratory diagnostics and private pharmacy drugs are the #1 drivers of utilization at 51%. But second to that, the actual conditions that are driving that. So we realize hypertension, secondary, primary hypertension, again, glaucoma, cancers, diabetes, and basically other eye conditions. So it's giving us a bit of a picture here. Most people utilize the scheme for diagnostic services and private pharmacy drugs to manage conditions that are related to NCDs. So the demand for drugs is around NCDs, is for NCDs. So then we said, okay, if this is the case, which condition drives the most for these services that are being demanded for? And so we split the utilization by the chronic HIV category, by the disability category, and by the other chronic condition. So what you see is that the HIV category, followed by the disability category, uses private pharmacy drugs and diagnostic services the most. Then you have the NCDs that are demanded very strongly by people that are on HIV as well as other chronic condition. So then we decided that let's go a little bit further to dig into that. So next slide. On the drugs, that was bundled as just drugs. So we said, what are the top 15 drugs that are demanded for the most? And these are the drugs that are demanded for the most. And these come straight from our dashboard. So we're able to say, okay, can we get the top 15 drugs by condition? And this is what comes out. What you clearly see is that there's a high demand for the management of NCDs among our target population. And these really require long-term care, focusing on blood sugar control, heart health, pain relief, and cancer therapy. Next slide. So we go a little bit further and say, okay, can we assess the per capita utilization by category? Yes, that was blocked figures in terms of utilization, but is there any heterogeneity in utilization across the categories? And yes. Now, you realize that though we have more people at 52% under the disability category, the capita utilization is the lowest. The capita utilization is high among people that are on HIV treatment. There are few, but on average, they utilize the most services, followed by other chronic conditions. And like I mentioned, we have a lot of people on HIV in other chronic conditions that we are yet to move on to the HIV category. And that is what you see there. So per capita utilization is high among people that are on ART treatment, on ART, sorry. Next slide. Then we say, okay, let's just focus on the HIV category and see what is demanded for the most. And there you have it, outpatient initial consultation. So there's high health-seeking behavior among individuals that are on ART. And then secondly, private pharmacy drugs. Now remember, these people are already on ART, but then they're demanding for private pharmacy drugs. And clearly, this is to respond to the other conditions, so what you may call secondary conditions. These are the NCDs that are really being treated here. And then inpatient optical services, outpatient radiology, diagnostic services, and the rest. So you see that clearly the story is that it's not enough that you have the ART drugs. There is more that is required for one to be on an effective treatment plan. Next. And then we do the same for disability category. Again, you see that, okay, the first high driver is outpatient initial consultation, which speaks to the unmet need for healthcare services. Now they can access services because they're part of the scheme. The second one is pathology and radiology, diagnostic services. But you realize that for HIV, the second one was private pharmacy drugs. So for people on ART, they demand more private pharmacy drugs than those that are disabled. And then, of course, the rest follows through. Next. Then we looked at the other chronic condition category, and you see the similarity with the HIV category. First, you have outpatient initial consultation, and followed by private pharmacy drugs, which tells you that we have a lot of people that are on ART within this category that are yet to be moved onto the classification. So what do we pick from this initial analysis, which is really focusing on the first 1 year? Diagnostic services and private pharmacy drugs are the highest in demand. They're the highest in demand. And certainly, if we're going to look at effective treatment, we have to look at beyond just the condition of that member, the primary condition, there are other secondary conditions that need to be looked at. For HIV, really the highest expenditure is the other drugs. So that's a key driver that we have to look at. And NCDs, hypertension, diabetes, and cancer are big conditions, especially for people on ART. So is there a correlation between being on ART and developing NCDs and cancer for that matter? I think that's what we are seeing now. There's a high demand for cancer drugs by people who are on ART treatment. So I think the medics can help us to try to justify that correlation. And then, of course, like I said, the highest per capita utilization that we have picked so far, even though they are not the highest in terms of number, is coming from the persons on ART. And obviously that speaks to the need for secondary conditions to be taken care of. And so far, of course, the primary evidence is we have interim sustainability. We need to allow the pilot to grow and see whether indeed this can hold. And if it doesn't hold, if that utilization breaks the revenue barrier, by how much would the cross-subsidization be required in order to keep it solvent? Next. Then, of course, this is just what I mentioned, and those are the actual drugs that we are paying for with regards to cancer treatment, and those are the actual drugs with regards to chronic pain drugs and NCDs. And then, of course, we're also seeing, very interesting, a very high demand for vitamins and calcium supplements among people who are on ART treatment. So is this responding to nutritional needs and immune support? And if it is, imagine what would be the case if they're not part of the scheme. They would have to pay out of pocket in order to satisfy that need. And then, of course, diabetes management is a big issue, especially for people on ART, as well as those other chronic conditions that we have identified. So overall, being on ART, what we're seeing is presents an intersection of demands around cancer, diabetes, neuropathy, and cardiovascular diseases that require an integrated approach in order to manage. And that is only possible, of course, if they're part of a scheme that has a generous benefit package that allows for those services to be accessed. Next and final slide. Sorry? Yeah, next. Okay, great. So, so this is just what we think the scheme with the interim results makes sense of, right? The pooling of resources and a single pool rather than a fragmented approach allows for additional investments and allows for people to access additional services beyond the drugs that they get. And secondly, us being a strategic purchaser. So we determine the price at which we buy the services for. So we're a price maker in the market, and that allows us to have flexibility in controlling our expenditure. And I think the integration of services, HIV and TB and malaria services into the scheme allows for a better coordination of service delivery and ensuring that our members have ease of access to the services they need without any fragmentation when they go to a facility. So briefly, that's what we have done so far in the last 1 year. Thank you.
Thank you so much, Mr. Mono. I think this was enlightening. I don't know about you, but I really love that dashboard. It's really what we need for policy making, real-time data. So thank you so much. I think we'll have our last but not least country presentation. This time we'll call Dr. Ponu Armand Noel Kwasi, health finance specialist and expert at the General Directorate of Universal Health Coverage in the Ministry of Health in Côte d'Ivoire. Welcome him, please, with applause. Thank you. So I heard that the Zoom might be back on in terms of translation. You might want to try it because he's doing his presentation in French. Yeah. Bienvenue et à vous.
Merci.
Je pense que la présentation est... I think it's back on the Zoom. Okay, monsieur, vous pouvez nous montrer la présentation, s'il vous plaît.
The presentation is this one. Yes. Okay.
C'est ça?
Mm.
Okay.
Ok, merci. Donc, comme l'a dit la présentatrice, je vais faire ma présentation en anglais et en français plutôt. Faut signaler qu'en Côte d'Ivoire, nous sommes au stade de conception du projet avec le Fonds mondial et qui a pour objectif d'intégrer le VIH dans la politique d'assurance maladie. Déjà, cette diapo pour montrer un peu l'architecture du financement de la santé en Côte d'Ivoire. Et comme vous le voyez, on a une part importante des financements qui sont encore des paiements directs, malgré l'augmentation du financement public dans la part du financement. En termes de dépenses per capita, on voit également que les dépenses publiques per capita sont encore à un niveau faible, à $38 en 2021, à $32 en 2022. Diapo. Le dernier élément qu'on voulait vous présenter ici, c'est l'évolution des paiements directs, puisque nous sommes en train de parler d'assurance. Et vous voyez, il y a une tendance à la baisse des paiements directs pour le cas de la Côte d'Ivoire. Est-ce que cette tendance à la baisse est liée aux politiques publiques? Est-ce que cette tendance à la baisse est liée à une évolution naturelle de la baisse des dépenses publiques? Ou est-ce que cela est lié à l'assurance? Je pense que des analyses plus approfondies permettront de comprendre cette tendance, mais le paiement direct reste encore plus élevé, très élevé, et cela pourrait constituer un obstacle à l'accès aux soins pour les populations. Diapo. L'autre élément que nous voulons partager avec vous, c'est la réforme de l'assurance maladie qui est en cours en Côte d'Ivoire. La loi a été votée en 2014 et la Côte d'Ivoire a fait l'option de mettre en place une assurance maladie obligatoire et qui a pour objectif d'assurer l'accès aux soins aux populations, surtout les plus vulnérables. Et dans ce cadre, dans la conception, il y a deux régimes qui ont été mis en place. Le premier régime qui est appelé régime de base, qui est contributif, pour lequel une contribution par personne et par mois est demandée à hauteur de 1,6 $ par personne et par mois, et un volet de régime assistance médicale qui concerne les personnes économiquement faibles dont la prise en charge est assurée par l'État. Diapo. Donc ici, nous allons mettre un accent sur le régime d'assistance médicale, puisque l'objet de cette rencontre, c'est la population vulnérable. Et les modalités de mise en œuvre de cette assistance médicale est définie à travers un décret qui a été pris en 2018, qui définit la cible de ce régime d'assistance médicale. Et donc, lorsque vous regardez dans la cible, il y a une des cibles qui concerne les personnes économiquement faibles, et la sélection se fait via l'enquête qui utilise la méthode proximine testing et suivi d'une validation communautaire pour enrôler les personnes qui sont identifiées économiquement faibles et les ayants droit. Et d'autres cibles sont identifiées également, notamment les personnes pensionnaires des orphelinats et les personnes handicapées. Diapo. Diapo. Laisse. OK, malgré, comme on l'a dit, l'assurance, la loi a été adoptée en 2014, mais il y a une enquête qui a été faite en 2021, l'enquête sur le niveau de vie, qui montre que les couvertures en termes d'assurance restent faibles. Et lorsqu'on compare la couverture des populations non pauvres et les populations pauvres, on voit que la couverture pour les populations pauvres était autour de 28%, alors que les populations non pauvres étaient autour de 8%, alors que la couverture pour les populations pauvres restait à 0,8% et avec une couverture globale de 5,3%. Donc, ce qui montre qu'il y a encore des défis énormes à faire pour assurer une couverture des populations avec l'assurance maladie qui est une couverture du risque maladie. N'est-ce? L'autre élément, vous voyez ici l'évolution du financement de l'assurance maladie dans le financement global de la santé. De 2010 jusqu'en 2016, nous étions dans une situation stable. Depuis 2017, on a une tendance à la hausse, mais ce taux-là reste encore très faible et représente à peine 6% du financement de la santé. Donc ici, on voit qu'une bonne partie des financements reste encore d'autres sources en dehors de l'assurance maladie sociale. N'est-ce? Quels sont les avantages liés à l'assurance? Il y a le volet protection financière qui assure une couverture à 70% pour les personnes qui sont inscrites au régime général de base et une couverture à 100% pour les personnes dites vulnérables, avec un panier qui comporte environ 170 pathologies et 964 médicaments et qui couvre un certain nombre de prestations. Au 31 décembre, les chiffres ont évolué. Sur 32 millions d'habitants, on était autour de 17 millions, soit 54% de personnes qui ont été enrôlées. Et parmi ces personnes-là, on est autour de 600 000 personnes indigentes, donc personnes économiquement faibles. Et parmi les 17 millions enrôlés, on a environ 9 millions qui avaient pu récupérer leurs cartes, donc 460 000 personnes indigentes. Concernant le VIH de façon spécifique, il y a eu des évaluations qui ont été faites à travers le CLM, qui est le Community Lead Management, qui a été fait par des organisations de lutte contre le VIH pour montrer un peu l'accès aux soins à travers l'assurance maladie pour les personnes vivant avec le VIH. Et il y a deux évaluations qui ont été effectuées en octobre 2023 sur un échantillonnage de 2427. L'analyse a montré que 39% des populations vivant avec le VIH étaient enrôlés dans le dispositif de la CMU et seulement 9% avaient pu utiliser leur carte pour avoir accès aux soins. La même évaluation a été faite en octobre 2024, une année après, avec un échantillon de 1887 personnes et la couverture en termes de personnes enrôlées était autour de 53%, donc une personne sur deux, et l'utilisation de la carte était autour de 18%. Ici, certes, l'échantillon n'est pas représentatif des personnes vivant avec le VIH, qui représente un effectif de 420 000 personnes en Côte d'Ivoire, mais cette analyse montre que des personnes vivant avec le VIH sont déjà inscrites dans le dispositif et que des efforts doivent être faits pour améliorer l'accès, surtout l'usage de la carte pour bénéficier des prestations. Le projet qui sera supporté par le Fonds mondial, j'ai dit, on est au stade de conception, mais déjà les premières réflexions ont permis d'identifier des populations cibles qui sont les personnes vivant avec le VIH essentiellement et des personnes à leur charge, et une deuxième cible qui sont les enfants et orphelins rendus vulnérables du fait du VIH. Donc, pour l'instant, dans les premières discussions, voici les deux cibles qui ont été identifiées. Le financement va couvrir environ 18 000 personnes vivant avec le VIH et leurs personnes en charge sur les 420 000 personnes vivant avec le VIH que la Côte d'Ivoire connaît. Donc, on est à peine 1% de cette population qui va être couverte. Yes. Le projet va durer sur 2 ans avec $1 million. Et l'une des innovations aussi, je pense, à travers ce financement-là, c'est que le financement va transiter via l'unité de coordination des financements Banque mondiale, donc ce qui va éviter d'avoir une unité de gestion qui va gérer spécifiquement ce financement-là. Donc, ça va réduire la fragmentation. Le projet, quelle est la stratégie qui va être utilisée, va servir à payer la cotisation des personnes vivant avec le VIH. Donc, comme je l'ai dit, la cotisation, c'est de $1,6 par personne et par mois. Donc, le projet va financer. Et dans le dispositif, ce projet va financer le ticket modérateur. Donc, ça veut dire que les personnes vivant avec le VIH, les 18 000 personnes qui sont éligibles, vont pouvoir utiliser les services sans payer le ticket modérateur, donc couvert à 100%. Et le choix des 18 000 bénéficiaires a été fait sur la base du coût moyen de prise en charge qui a été effectué par la Caisse nationale d'assurance maladie pour voir quel est le coût qu'une personne vivant avec le VIH pourrait coûter à l'assurance. Et à partir de cette estimation, nous avons pu identifier les 18 000 bénéficiaires. Diapo. Pour la stratégie de mise en œuvre, va se faire en plusieurs étapes. D'abord, il y aura l'étape d'enrôlement. Et cette étape va se faire de façon participative et impliquer le réseau des personnes vivant avec le VIH. Et toutes les autres organisations. Et les organisations comme l'ONU-SIDA vont être impliquées dans la sensibilisation des populations. Deuxièmement, en Côte d'Ivoire, dans le cadre de l'assurance, des dispositifs de production sur place des cartes ont été mis en place. Et donc, dans le cadre de ce projet, les personnes vivant avec le VIH vont être orientées vers ces sites-là pour qu'une fois enrôlés, ils puissent avoir leur carte. Et des discussions sont en cours pour effectivement effectuer l'enrôlement aussi dans des sites de prise en charge des personnes vivant avec le VIH. Une fois les personnes enrôlées, le réseau des personnes vivant avec le VIH va établir une liste de toutes les personnes enrôlées et transmettre cette liste à la Caisse nationale d'assurance maladie. À ce moment-là, la Caisse va faire une sorte de tri pour voir sur la liste qui a été transmise, est-ce qu'il y a des personnes qui sont déjà inscrites au régime d'assistance médicale. Donc, retirer ces personnes. Est-ce que parmi les personnes vivant avec le VIH, il y a des fonctionnaires, il y a des agents du secteur privé formel? Il faut rappeler que pour cette catégorie, les prélèvements se font de façon obligatoire. Et il y a une autre catégorie également, les planteurs café-cacao, dont le paiement est assuré par leur organisation. Donc, tout ça pour éviter qu'il y ait une duplication dans la prise en charge. Donc, c'est des personnes qui ne sont ni déjà inscrites au RAM, ni fonctionnaires ou dans le secteur privé, ni planteurs café-cacao qui vont être éligibles à ce financement. Ensuite, des critères d'éligibilité ont été faits pour valider cette liste. Je vais revenir là-dessus tout à l'heure. Et puis, ensuite, lorsque cette liste sera établie, il y a une phase d'analyse qui va être faite par les assistants sociaux qui travaillent avec les ONG, qui sont au quotidien avec les personnes vivant avec le VIH et qui connaissent leurs besoins pour s'assurer que les personnes retenues répondent vraiment à des populations qui ont le plus de besoins, vu que la cible est assez limitée. Quels sont les organes qui ont été mis en place dans cette phase de conception? D'abord, on a un comité de haut niveau dans lequel siège la Direction générale de la couverture maladie universelle et le programme national de lutte contre le sida au compte du ministère de la Santé. au compte du ministère de la Protection sociale, on a un des conseillers du ministre de la Protection sociale et la Caisse nationale d'assurance maladie qui assure la régulation de tous les dispositifs qui sont membres et les organisations de personnes vivant avec le VIH, l'ONU-SIDA, le Fonds mondial et la Banque mondiale sont membres de cette équipe-là. Et le rôle, c'est de vraiment valider toutes les étapes de la mise en œuvre et s'assurer et faire le suivi de la mise en œuvre. Ensuite, l'un des acteurs importants, c'est le réseau des personnes vivant avec le VIH, avec l'ensemble des ONG impliquées dans la lutte contre le VIH et qui, eux, dans leur contribution, déjà, aujourd'hui, ont recruté déjà, par exemple, un consultant qui a pour mission d'affiner les critères et de discuter avec toutes les organisations pour s'assurer que les besoins des personnes vivant avec le VIH ont été pris en compte dans le projet. Ensuite, un mécanisme de suivi qui va être mis en place pour évaluer la prise en charge effectuée à travers la supervision, à travers le CLM qui est le Community Lead Management qui est fait par les ONG et à travers un suivi hebdomadaire de l'accès aux soins pour les populations bénéficiaires. Sur le panier de soins, aujourd'hui, cette diapo montre un peu le panier de soins de la CMU. Diapo. Et ce que nous sommes en train de faire en ce moment, c'est faire une analyse croisée entre les prestations qui sont des personnes vivant avec le VIH qui sont couvertes à travers les différents programmes et ce panier de soins-là pour pouvoir avoir des discussions en termes d'ajustement. À titre d'exemple, lorsqu'on a regardé les médicaments qui sont remboursés dans le cadre de la CMU, seulement une molécule qui rentre dans la prise en charge des personnes vivant avec le VIH. Donc, sur les 964 molécules, il y a une seule molécule qui rentre dans le cadre de la prise en charge des personnes vivant avec le VIH qui est intégrée dans ce panier de médicaments. Donc, pour chaque type de prestation, cette analyse est en train d'être affinée pour voir le gap et s'assurer que lorsque le projet sera déployé, les besoins primaires des personnes vivant avec le VIH sont effectivement intégrés dans le panier de soins pour une prise en charge effective. Next. Déjà, donc, comme je l'ai dit, nous sommes au stade de conception, mais les premières leçons que nous tirons, c'est la question de la confidentialité. Et donc, parce que lorsqu'on discute avec toutes les organisations, ils insistent sur le fait que tout ce processus-là doit garantir la confidentialité des personnes vivant avec le VIH. Ensuite, la deuxième leçon, c'est les personnes en charge. Dans le design de la CMU, c'est le bénéficiaire et les ayants droit, qui sont soit des enfants légaux ou des enfants adoptés. Lorsque nous avons discuté avec les organisations des personnes vivant avec le VIH, ils ont une autre catégorie de personnes qui sont des ayants droit et qu'ils souhaitent intégrer dans le processus. Donc, des discussions sont en cours pour la prise en compte de ces catégories. Et les deux derniers points, c'est la sélection des 18 000 bénéficiaires. Comme je l'ai dit, on a 420 000 personnes vivant avec le VIH. On doit sélectionner 18 000 bénéficiaires plus les ayants droit. Donc, il y a un défi de sélection et s'assurer que nous sélectionnons vraiment les personnes vulnérables qui ont le plus de besoins. Et le dernier, comme je l'ai dit précédemment, c'est vraiment l'intégration des besoins spécifiques des personnes vivant avec le VIH dans le panier de soins de la couverture maladie universelle. Comme élément, comme conclusion, dans cette phase de conception, il y a 3 éléments que nous voulons noter. D'abord, l'enrôlement dans personnes vivant avec le VIH et leur confidentialité. L'équité pour les bénéficiaires. Donc, comment s'assurer qu'on n'intègre pas dans le dispositif des gens qui n'ont pas les besoins de base et que nous puissions prendre en compte vraiment ceux qui ont les besoins les plus critiques. L'autre élément, c'est une réflexion à long terme, et je pense que les présentations précédentes l'ont relevé. Dans ce contexte d'intégration du VIH dans le cadre de la Côte d'Ivoire, du paludisme et de la tuberculose, dans le programme d'assurance maladie, quel pourrait être le rôle des programmes verticaux qui sont financés aujourd'hui par le Fonds mondial dans l'ensemble de ce dispositif-là pour essayer de réduire la fragmentation des financements qui vont vers ces populations cibles-là, parce qu'aujourd'hui, dans le modèle actuel, une partie des financements vont vers les programmes, une partie des financements va être orientée vers l'assurance maladie et nos parties de financement sont orientées vers des ONG qui interviennent sur la thématique. Donc, comment dans cette réflexion, dans ce processus de réduction de la fragmentation et de l'intégration de ces pathologies dans les programmes d'assurance maladie, quel nouveau rôle on pourrait donner à ces programmes verticaux-là pour renforcer la prise en charge de ces personnes-là. Donc, voici, mesdames et messieurs, présenter l'expérience de conception en cours en Côte d'Ivoire et merci pour votre aimable attention.
Merci beaucoup, Dr. Kwasi. Je pense que c'était vraiment intéressant comme présentation. Bon, moi, je note vraiment la place donnée à la société civile, les organisations de PV, VIH et bien sûr les ONG. Je pense qu'il est vraiment important d'avoir leur voix dans la définition de ces paniers de soins. Et l'exemple de la Côte d'Ivoire est vraiment très enrichissante dans ce sens. Donc maintenant, d'ailleurs, docteur Kwasi pouvait rester au niveau du podium. We'll switch to a panel discussion with some of the presenters that we had earlier. And then as part of that, I think we can take just 2 or 3 questions of clarification, and then the panel can proceed because we're a little bit behind time. So I'll just ask our panelists to join the stage. So Dr. Kwasi, you can come up, please. And then we have Dr. Mono. You can also go. Thank you. All right. So in terms of the other panelists, let me call Dr. Regis Itimana. He is the Chief Benefit Officer at the Rwanda Social Security Board. Welcome, Dr. Regis. And then we have Professor Chima Onoka, Senior Technical Advisor to the Director General at the NHIS. Welcome. Last but not least, we have Dr. Bushkiku Hameza, Global Fund Coordinator, Ministry of Health, Zambia. Thank you so much, gentlemen. See, there's no women in the panel. We'll do better next time. Okay, so the panel will be, yes, I'm gonna call him. The panel will be moderated by Alex Winch. He's a health financing advocacy specialist at the Global Fund. Welcome, Alex. Thank you. So as you go, I'll just ask for volunteers for the 2, 3 questions of clarification, and then we'll get a mic for you. Get this.
Thank you, thank you. I just also want to introduce maybe the vacant seat is for Natila Tavangshu from the Global Fund, who will be the chair for the panel discussion, and as well. There we go. So yes, round of applause, please, for our presentations and our speakers. Wow. So I have 30 minutes now to dive into the panel discussion, and it's also got quite a long title though. So it's around mechanisms for monitoring and evaluation of the pilots and the role that evidence and lessons from these investments could play in reinforcing government investments in cross-subsidizing the poor, including considerations for other innovations that could be adopted by countries to strengthen sustainability. Now, there's a lot there. So we'll take that and break that down piece by piece, I think, as we go through the panel discussion. I firstly want to start maybe with a question for our chair, Natila, who I work with as a colleague in the Global Fund, because what we've heard today and the presentations from the colleagues from the different various pilots and health insurance agencies and schemes is a big departure for the Global Fund from business as usual. And so as usual, there's a degree of risk and uncertainty weighing against obviously the potential benefits for these pilots. So, and I'm sure not only for Natila and the rest of the team, added complexity, but also for those applying for Global Fund money from the different schemes in the processes. So I just really want to hear, why do you think this is worth the additional challenge, the additional burden, and what would you like to see in terms of vision going forward? So maybe a few thoughts on that. And I will also then maybe ask our other panelists. Thank you, Nita.
Okay, so for us, it is indeed a departure a little bit, maybe in Africa, because it is something that in Asia we have started a little bit earlier. But this goes in line with the developments in the African region, with the prominence that universal health coverage has taken, and with universal health coverage, also financial protection of populations and increasing investments in health. So for us as Global Fund, as I said, the worthwhile is double-fold, that we invest in the 3 diseases, but we overall want to invest in sustainable, prosperous, and equitable health systems in Africa. So as the continent is taking the plight and is stepping up, we would like to step up together with them to help them in this vision. So it is one way of, regardless of us investing in 3 diseases, these 3 diseases, they don't exist in a vacuum. They benefit largely from the health systems in the continent. They occupy the health systems in the continent because they constitute a burden of disease. And therefore, it is in the benefits of everybody, including the prosperity and the strengthening of health financing in Africa, that Global Fund, supports these initiatives, especially now that they are at the start and they need all hands on deck. The second thing is the patient-centered approach, and what I mentioned, but also all the colleagues mentioned, that you have people that due to the successes in the 3 programs and our collective effort, they live longer, they live lives like everybody, and they get affected by other conditions rather than their basic condition. And by giving them the medicine for their basic condition, we don't necessarily protect them from undue financial health, for their other health conditions. And at the end of the day, also the outcomes of our programs will be compromised because if the ultimate goal is healthy life years gained, it is not important that they are not from HIV. If they are on the same people from other conditions, then they are nevertheless lost healthy life years. So this was the idea, but then as a fund that has donors, that has interest groups, that has a mandate to deliver for people in the 3 disease groups, this is also a little bit complex for us, because then we need to show some connection between the investment that we are doing and the results that we want to see on people of our concern. So this is number 1. Number 2, as I said, it is a discrepancy between the schemes that are nascent and between the programs that we support, where people are more covered for the programs that we support, and also the disbalance that might come to the government had they take these services on board. And then it is, whatever comes with it. So making sure that the money is spent properly, that the money goes where it is intended, and also that the money that we pay is enough, because as we heard from Zambia, they see the population of our concerns, they utilize a lot the services. And so if we were supposed to pay to subsidize these people en masse, and the rest of the population is not that much enrolled, then this is problematic, because the scheme will not become viable. So that's why we started small. We started with these pilots to first of all have a proof of concept to secondly assure all our colleagues in the Global Fund, but also in our profession that deal with the diseases themselves, that we are not taking away from the beneficiaries, but we are creating conditions for them to have better health. And then we wanted to see how much realistically these people cost to the system, so that if we go at scale, we'll do a reimbursement that is fair. And then we wanted as well to see the reason that the services for these people have been a little bit outside the health system is also about structural barriers and stigma and discrimination. So we wanted to see as well that through these pilots, these people are treated well, regardless by the system, so that their experiences are well. So these are all the things that made us think go a little bit small. We would have wanted to go bigger, because you see some of the figures are 1.5 million, 1 million. But these have been negotiations in countries, and we still have work to do with our colleagues, also with CCMs and with colleagues working on the diseases, but this is a good start. We would be very keen. I'm very happy. These are my babies, so I'm very happy to see today that we are where we are, and we'll monitor the results and we'll make them available wherever, so that, as Regina said, now that we have taken formal steps to allow countries to request this type of support through Global Fund, so that colleagues here see about results, see how people went about it, and consider these interventions. And that on the other side, if we are going to go at bigger scale in the countries where we have already started, we do this in a fair way, and also always looking at the lessons learned and changing as we go forward.
Great, thank you, Natila. So next, I want to turn to Dr. Regis from Rwanda's Social Security Board. Rwanda obviously has the Rockstar community-based health insurance scheme that's been around for many years. I want to hear your reflections now you've heard about the 3 different pilots. What are your takeaways that you've got from this, and do you think this is kind of the right direction of travel for development assistance such as the Global Fund? Then I'm reading the room. There's a lot of people who are still here. This is excellent. And we'll take a few questions afterwards from those. So maybe just think them through and prepare them, and we'll take a few hands after Dr. Regis's intervention. Thank you.
Thank you very much. It was very inspiring to see all the pilot projects, all of them having some common characteristics, but also different particularities in each country. And I think the intention is a good one. The reason probably Rwanda was not selected to present among the pilot, it's because it would be too late for us to present as a pilot, because we started this more than 15 years ago, when in 2010, after almost 10 years of implementation of community-based health insurance, there was an engagement with Global Fund to start supporting government in subsidizing vulnerable groups, among whom people on HIV/TB treatment were included. And I think, as my colleagues were talking about, were presenting, actually that gives a boost. I think she mentioned the word boost, because every time we're enrolling people, we're starting not from zero, because everyone who is vulnerable was already covered from day one of the year. So we usually start our year the 1st of July. So we're starting around 20% of coverage already of the poor, among whom people with HIV, TB, and malaria are covered by government with support of Global Fund. It started, I think, when I was looking at the numbers, Global Fund was subsidizing about 50% of the coverage of the poor. But maybe the difference I've seen, targeting was not based on being on ARV or not, ORT or not. It was, there is a system we are using that to target vulnerable families. It's not used for health insurance only, it's used for everything, including social assistance, including social protection. It's not run by the insurance, it's run by the ministry in charge of social affairs. The people will benefit among many other programs, including cash transfers, including jobs. So we take advantage of that system to target those who will receive government support. So if you are on ART treatment and you don't fulfill those criteria, you will not be included, but because we know we are capable of paying your own premium, but you will have access to services. So I think maybe that's what I found as a difference. It was total integration. It's not targeting the specific group of people. It's targeting based on your socioeconomic conditions. And so that helped actually the scale up of the health insurance. Since then, we have recorded above 75% of coverage. Now, since the last, I would say the last 7 to 10 years, it was above 85% of coverage. Of course, there are many other factors, including the political engagement, especially at the local level, where every district, every mayor will have a target to reach. Their target is always 100%. None of them reaches it, but at least they try. And when they try, they arrive at 90, and we encourage them, and they get rewards for reaching the target. But also, the second factor I can say is also the continuous improvement of the package. Our year starts in July. We are in March. So already people have started paying. We have not yet launched the campaign for this year because they know at one time last year or 2 years ago, someone had these complicated cases. And as we are having more non-communicable diseases, they'll see how much the insurance is covering for them. The third element is government subsidies. Maybe our premiums are close to what Zambia was talking about. It can't cover all the costs. So recently, 5 years ago, government identified other innovative financing that are complementing premiums paid by people. So joining CBHI actually gives you, today your premium are contributed up to 40% of the total cost of the total revenues to CBHI. So you get access to that 60% when you pay your small premium. So I think that is also something that people see, that they know what they're paying is not sufficient, and government can't stop providing benefits because it was not sufficient. That's why we kept increasing the package and also identifying other alternative sources of revenues. So in a nutshell, I think this is very promising. It's a very good start. But probably what we can say is, as we go along with this pilot, probably thinking more system-wide, targeting everyone who is not disease-specific. Secondly, also supporting these government systems. We realize actually we have a challenge of targeting the actual poor people. And as government, we are now moving to the old system that was criticized to be more subjective, because community members would meet and determine who is poor. There were a few criteria that were set up, but now we are moving to a system where, using technology, we can know how many assets each household has. With the single ID, we can know let's say, the size of the land you own, because it is linked to ID. We can know which asset you own. You can know which salary you are earning, in order to be more objective in determining who deserves this support. I think these are some of the country systems that Global Fund can support to sustain these efforts. Thank you.
Thank you very much. Thank you. That was excellent. So a few questions now from the audience. So we got, I'll leave one on the microphones here and just hand it over. Right, we've got a few hands here. So can you also please introduce yourselves when you ask your questions? We'll come ladies first.
Thank you so much. So we don't have any lady on the panel. So my name is Bolanle. I work for APS Global in Nigeria. And it's a pleasure to be here and listen to all this wonderful work from colleagues around African countries. So I'm glad Professor Chima is on that seat. But my first question is about sustainability. and you know where I'm coming from. So this work that Global Fund is doing is actually not on a tabula rasa. It's something that's been done in, small quantum of work by USAID in Nigeria. And the difference, I guess, was that we're not paying premiums. All right. So Nigeria has a vulnerable fund. The Basic Healthcare Provision Fund has been running for years. States also have equity fund. So our model was to support the states to enroll PLHIV after administering the vulnerability assessment tool. Because like someone presented earlier, this is a very heterogeneous group. Not every PLHIV is vulnerable, socially in terms of financial vulnerability. Some can pay, and we've actually seen within our program, PLHIV that paid their own premium due to the sensitization that came from this process that we're doing. And so my question is, it could be answered by everyone, including Global Fund, but certainly for Nigeria, I think we should start looking at sustainability, about how we can support our country to enroll our vulnerable PLHIV and TB patients using our own vulnerable funds, either the Basic Healthcare Provision Fund or the state equity funds. We've achieved this in at least 2 states. And an alarm went up in my head when we were talking about the premiums, and I said, assuming that we're paying premiums, what will happen to the 7,000 PLHIV in Lagos that were enrolled on health insurance using Basic Health Provision Fund and the State Equity Fund, and the 3,000 in Kano? So I'm happy this is happening, because this initiative will help improve our health insurance coverage on the short run, immediately. That's what we want. But on the long term, we should start looking at how we can absorb this and mainstream it into our major, vulnerable funds in different ways. And also to say that it is important that the vulnerability assessment, even within this program, is uniform, and the National HIV and STI Control Program, NASCAP, has a vulnerability assessment tool that the states can adopt. I have questions for Zambia, but I guess colleague also wants to talk. But let me just drop this for Zambia. I want to ask if there's a plan for you to integrate HIV-specific services at any point. Again, it's a sustainability question. Have non-HIV specific services, which are needed, no doubt, but true sustainability for the care of HIV positive patients lies in you being able to support HIV specific services. And it's in stages. You can't get there overnight. I know in Asia, like she said, Vietnam, they now pay for their drugs from their health insurance program for both HIV and TB. And that is what we should be aiming for in Africa. Thank you.
Thank you. And maybe just we'll keep it quick, because I know there's going to be a lot of questions.
Yeah, thank you. My name is Chidunga Hazurike from APS Global. I work in Nigeria. So my questions are to both Nigeria and Zambia regarding the sustainability mechanism for graduating from support. Now, we've done this for 3 years in Lagos and in Kano, but that means government has paid at least 2 cycles of premium for vulnerable PLHIVs. And now, because the way we targeted was just for health insurance, we didn't integrate, or Nigeria is not really integrating their social safety net programs with health insurance yet. Now, what is the plan even for Global Fund as it rolls out its pilot in the other 4 states to really graduate from this poor and vulnerable PLHIV, so that they can either pay their premiums by themselves, or either by a percentage, or all of it? Then I wanted to ask for Zambia, your claims, do you pay by capitation, or do you pay for fee for service? And then the question again for Nigeria, our basic healthcare provision, our unit of targeting is individuals. The lessons we're learning from Zambia is that they're using households. Perhaps it will be helpful for us, in trying to merge our social safety net programs to also go by households, and that way will cover not just the PLHIV person in a particular household, will also cover the whole households. Thank you.
Thank you. And so who else has that? Now I'm aware we've already had 2 for Nigeria. So is your question for Nigeria or for all of our panelists?
It's for both Nigeria and Zambia. Okay, thank you, Dr. Abubakar and Mr. Molu for that presentation. So mine I'm just curious, because there's a common denominator across the 2 countries are presented. There's no TB screening as part of the benefit package. Is there any reason for that? I'm just curious, because across the 2 countries, I didn't see that. Then secondly, for Zambia, I know you did some intercessions for HIV. To also be nice to have those intercessions for TB. So the TB patients, what other drugs are they buying or are they getting from the pharmacy, so that it can also help us the way you have for HIV that we're seeing diabetes, hypertension, and cancer. So the patients that are on TB medications or other comorbidities or conditions, are they getting drugs? So thank you.
Perfect, perfect. And we'll take one more. We'll go to my colleague here. We'll hopefully do another round. Yeah, thank you.
Thank you very much. My name is Francis Ayomo. I'm a doctoral researcher at the University of Oxford, and I've worked with the Ministry of Health in Nigeria. Question first to Natila and her team, trying to find out what's the end game? What does success look like for you at the, I know this is a pilot, but where do you see this? Are you planning it gets to a phase where maybe linking to sustainability, they are self-sufficient and Global Fund finds another thing to use that money for? Or so that's one. And then to the panelists, still like an end game question. Where does this lead to? And how does this pilot connect to broader health insurance mechanisms? Like, as we know, it's still part of the whole broad health insurance system. So how does what we're doing for HIV, TB, and malaria connect to the broader health insurance system in the different countries? Thank you.
Thank you for those. It's excellent. So we had three, I think we could group them as three. There was one question very much around sustainability and transition of these pilots eventually. There's one about the rich data, I think, that was presented by Zambia. And then there was Endgame, which all nicely chime with what I already had planned for our panelists. So who would like to kick us off with responding on any of those? Maybe Dr. Chima, yeah.
All right, thank you very much, and very good questions. I think it's really been, I mean, we've had very rich contributions to the discussion from those presentations that came from various countries and then from Rwanda as well. For sustainability, I'll really try to focus on that. Well, one of the good things that is happening is that, especially with the one in Nigeria, is this issue of government, even at the national level, so the National Health Insurance Authority being involved in it. And there are two components: the programmatic aspect of things, and then NHI in Nigeria also having regulatory roles. So what exactly are people being provided with in the first case? What is being sustained? What are we talking about that we intend to sustain? What has been happening from that side is whatever is going on in states, whatever people have tried to do, whether it's with people living with HIV/AIDS or other people, what is it that is a benefit package? And maybe like what was said earlier, what is a benefit design? Some of the things that have come out, there are people that, you know, have covered services. They'll tell you they've covered while you're at work. You're not covered while you're at home. Malaria is covered, but there is something when you step out of your room or when the mosquito bites in a certain way, then the malaria is not covered. You know, different things. Now, from that point of being a regulator, this pilot is one of those things that we're using to also shape that narrative. What is being covered, the benefit has to be clearly defined and agreed on, and then it can be portable. If the person who has, for some reason, who is living with HIV/AIDS moves from one part of the country to the other part of the country, that's another state. Will the person continue to receive services or not? How do we solve that problem? Those are the things that we're raising as issues, and we're going to use this pilot to, you know, drive the conversation and have what works. Number two is also of course, having government involved from the onset is a journey towards sustainability in the way it's been done. I mean, sustainability, we can talk about all the things in terms of resources, but if the objectives are clearly defined from the beginning and government is aligned and working and shaping its paths, the pathway towards that end that we're looking at, then the chance is, it will be the resources that we're looking at, which is, just one aspect. So when that is, we've started things like, okay, which health facilities are being used? Ordinarily, if this were to go as a parallel intervention, we will start doing accreditation of facilities and all of that. That's not what's going on here. We've looked at the provider networks, providers that have been accredited already. There is no new accreditation. The ones that, where people have been receiving care, people with HIV/AIDS, and were not accredited for other health insurance services. So those are now the ones that we're focusing on in those states. And so that already, it's a big achievement in terms of driving efficiency. I think it's also key when we talk about that, because for all of these things to get sustained, the figures that we have emerging from like actuarial valuations should be real. And really glad about what came up from Zambia, because that has been a cause of concern for us. It's not just about even, those services that they are getting, but there are some places where some of the operational things have been handled by partners. How much does that cost? Is it part of the admin charge, which is built into typical premiums? And then when you are doing your actuarial valuation, you should account for that. Is it included? Is it not? The recent events have further deepened our conversation on that. There are things that we want to answer, as we undertake this journey. And maybe the last thing I'll say is that, these discussions as they shape up, Nigeria's experience will probably bring in not just what's happening from a national level, but there are like 4 states plus Lagos. Each of them can stand as a country. Some various experiences, there's Lagos is like 20 million or so. Some other of those states, if you put all of them together, is more than 40 million people in terms of population. But different experiences, even though our targets and our indicators will be uniform, but the operational things, there are variations, and even people variations that will be unpacked by qualitative analysis. We hope that all that will come out as we answer questions, and maybe that will help solve a lot of problems even for other countries. Thank you.
That's perfect. Thank you, Dr. Chima. And I think you picked up on one thing I definitely spotted on the actuarial analysis. You have 2 studies underway, as I understood it, in the pilot. And Nima spoke of the actuarial analysis done to inform their benefits package, and with the support of ILO, I think was it as well. Maybe you could speak a little bit about that, because I know when we've supported this before, having actuaries, having the actuarial support within health insurance agencies is a big challenge. And maybe that's also something for Rwanda as well can reflect on there, as well as the other questions that are coming in. I wanted as well to bring in Dr. Punu. I think what you presented on your participatory approach when you engaged with the people living with HIV organizations, the civil society organizations, to identify those recipients. I think it would be great to speak about that in terms of, are you going to keep involving those organizations when it comes to monitoring and evaluating the success of the pilot, if that makes sense. Sorry, my French is very bad, but I hope that's okay. Thank you.
Thank you. I think the experience we have is quite similar to the experience from Nigeria, and so are the questions as well. So what's the end game? Maybe we start with that. The end game is that every Zambian should be part of the National Health Insurance Scheme, whether they're contributing directly out of their incomes or they are being supported by the state. So we take health as a public good, and ultimately it is the role of the state to ensure that every citizen has access to that. So we want to use this pilot as a trigger for government commitment to ensure that those that are exempt and need to be supported by the state are supported. And the pilot is really already integrated with a state-supported program, the social cash transfer program. So out of that $40 per month that the household gets, we're saying, if you're going to increase that, can you allocate $2.5 and let it go to the scheme? That way, the members will be integrated and fully supported by the state. So that's the end game. And I think the pilot will generate the evidence on what is the required contribution by the state to ensure that the scheme is sustainable. There was a question around the HIV-specific services. Right. So if you saw from my presentation, apart from primary services or preventive healthcare services and drugs, we cover everything around HIV management. So the only thing we're not covering under the scheme are the preventive services, the primary healthcare services, and the drugs. And I think what we're discussing now is what is the cost of these services? So we need to, first of all, identify the cost of HIV services, the entire continuum of care. Then we cost those services. And once we cost them, we know what the liability structure would be. Then we identify where we can get the additional resources, or within the scheme, change the contribution mechanisms to be able to cover for that. So the graduation, right? Are we going to keep these people onto the scheme? So because we're using a poverty targeting approach where only those that are deemed poor and vulnerable by the state are the ones we're supporting, if they graduate, that they're no longer poor and they're deemed to have graduated by the state, then they will no longer benefit from the subsidy. But I think what this would have done is they would appreciate the value of the service of being on the scheme. And because now they have the capacity to pay, they'll contribute based on that capacity to pay. Hence, you have sustainability. There was a question on the payment mechanism, fee for service versus capitation. So currently, we are running a combination of both. So fee for service and capitation. So in public hospitals, we basically have a capped amount per member that they can use. And then for services that are accessed in the private sector, we use fee for service. But as part of this pilot, we want to assess which model would be ideal. Of course, we know the challenges of fee for service in terms of oversupply of services. So we'll be piloting a capitation model for lower levels of care that our members will be accessing. Then finally, I think there was the issue of the TB services. Agreed. This year we want to dig a little bit deeper to ensure that we streamline the membership so that our service tracking is linked to the actual conditions so that we can identify the heterogeneity in service demand. But I think what you clearly see is that there is a bit of clustering around, so those mostly on art and in high TB areas demand kind of similar services. So we can already intuitively pick what they're demanding from there. I think in this second year of the phase of the pilot, we will dig a little bit deeper so that we can really get the actual figures. There was a question on actuarial analysis, right? So as part of this, we have integrated within the pilot. So the dashboard I showed you comes from what we call an actual evaluation dashboard. So we have a dashboard where we're able to track every month what the actual position of the fund is and the actual position of this pilot. So that when the claims go beyond the contributions, then we know the level of cross-subsidization that has to come, but also the level of contribution that will be required to keep it sustainable. Thank you.
Thank you. That's excellent. Super. We'll pass on.
OK, merci. Effectivement, comme vous l'avez dit, en Côte d'Ivoire, on a fait le choix de l'approche participative dans le cadre de la mise en œuvre de ce projet. Il faut rappeler que nous avons plusieurs organisations de personnes vivant avec le VIH et l'ensemble de ces organisations-là est regroupé dans un réseau qui est le réseau des personnes vivant avec le VIH. Donc, le niveau d'implication va se faire à 3 niveaux. Déjà, au niveau des différents organes de gouvernance, donc comme je l'ai dit, le comité de suivi de haut niveau dont le réseau est membre. Ensuite, le comité technique qui va faire un suivi hebdomadaire de la mise en œuvre. Et surtout, au niveau communautaire, il y a un outil qui est déjà utilisé, qui est le CLM, le Community Lead Monitoring, qui est un outil qui a été développé et mis en œuvre avec l'appui de l'ONU-SIDA. Et cet outil-là est utilisé par les personnes vivant avec le VIH. Donc, l'objectif, c'est aller faire une enquête communautaire pour évaluer l'enrôlement des personnes vivant avec le VIH, pour voir quel est le niveau d'enrôlement. Deuxième objectif, évaluer l'accès aux soins et identifier tous les obstacles liés à l'accès aux soins pour les populations, notamment les accès liés au système de santé, les accès liés à la discrimination, les accès liés à la prise en compte de l'ensemble des besoins, et tous ces éléments doivent être reversés au comité technique et au comité de haut niveau pour apporter une réponse adaptée. Et le dernier élément qu'il faut noter dans cette évaluation, ça va consister également à évaluer le niveau de satisfaction des personnes vivant avec le VIH et évaluer également l'éventuelle existence, persistance de paiement direct, alors que le processus prévoit une prise en compte de l'ensemble des frais. Et donc, cette analyse de persistance de paiement direct permettra de voir est-ce que l'ensemble des besoins est effectivement pris en compte dans le panier de soins, ou est-ce que ces paiements directs sont liés à des problèmes en lien avec l'ensemble du système de santé. Voilà, merci.
Merci. Thank you. And so I think I'd like to address a question to Dr. Baskiku, who's there right at the end who's the Global Funds Grant Coordinator within the Ministry of Health in Zambia. And maybe you would like to reflect upon the question of endgame from your perspective as well in the Ministry of Health. How do you see this fitting into the Ministry of Health's perspective on sustainability and movement towards domestic financing for health? Thank you.
Thank you very much. And I think when I listen to the other panelists here, it's like we're coming from the same country. So, I think a lot has been said with regard to sustainability. But I think what I would like to emphasize is the aspect that with these pilots, it's basically lessons that we need to learn. We're trying different approaches, different models in different contexts, with essentially the one principle of saving lives and providing good services for HIV, TB, and malaria. So we really need to ensure that we are rooted in the evidence that we are going to be able to generate. Again, I just want to re-emphasize the aspect of cost. Whenever we are discussing these kinds of approaches with those that make decisions, the first thing they ask us is how much. We really need to have a very good understanding in terms of how much these services are and what this minimum package looks like. I think back home in Zambia, we're having these discussions now, particularly around associated with the reduced fiscal space with regards to public health, service delivery. What is the minimum package? And last but not the least, I think what we also need to emphasize is the aspect that we should keep our eyes open for potential partnerships. This is where we need to grow the base in terms of who we can work with and partner moving forward. That will really help us kick through to sustainability. Thank you.
Super, thank you, thank you. And actually, I want to pick up on those last two pieces, cost and partnerships, to hear a little bit more from Rwanda on how they've been kind of doing that in their perspective, from your perspective. Thank you. And then we'll open up for questions again, maybe two more, and then round off, I think. Thank you.
Thank you. I think, and also related to sustainability, I think once you have a platform, as our colleague was mentioning, I think sustainability is assured. If I give maybe numbers, 10 years ago, Global Fund was contributing 3.3 million USD for the vulnerable population to be enrolled to the scheme. Last year, it was only 188,000. And I hear that this year, this can be dropped. But it doesn't mean that services are stopped to this group of people. So I think there is a way you can build a sustainable way of graduation out of this. And I think, as our colleague was saying, this is a lesson. You first build the system, and when system matures, I think we will find alternative way of financing these programs. And on your question about capacity and collaboration, I think we collaborate with a lot of people. Most of the time is about technical assistance for services that, so for capacity that we don't have in-house, because financing is already covered in a way or another through premiums through government subsidies, through various financing mechanisms to the scheme. But also we learn lesson and we realize there are some of the capacities that we need to build internally. So after receiving capacity in terms, if I give an example, in our new structure at the Rwanda Social Security Board, we have an actuarial unit for the first time. We will not wait once in 5 years because the regulator says so, or because one partner has money to help us with actuarial valuation. We'll be recruiting and training actuarial experts within the house to support all the other schemes that we have. I think it's a journey, and there is always a step into the journey, and we are still learning as we move along. Thank you.
Super, thank you. So final questions out to the audience. And I want to actually ask, among who we've got here, are there any from a Ministry of Health or from the government? From the Ministry of Finance would be the ultimate. I'd like to hear their perspectives. Anyone? Or if not, okay, that's fine. So let's go, final question at the back. And please introduce yourself.
Damiano Sokaka from Kenya, now at least not from Nigeria. On sustainability, the Kenyan government, we were having NHIF. The Kenyan government decided to expand this to cover as many people as possible. And the problem with pooling is in this part of the world is the problem of collecting and administration cost from those people who are in the informal sector. When the government expanded it, it is already having problems as we speak now. The problem is, and you are saying that will be sustainable, yet expansion is causing Kenyan problem. Even some providers are already moving out. They are saying they cannot be paid. The quality of healthcare, they are saying, is coming down. So I'm wondering, probably, are we getting it wrong from Kenya? The other one is if you go to, I research in healthcare, if you overemphasize financing healthcare, then you may be ignoring the other social determinants of health. As other social determinants of health may include things like clean water, things like, and we have found that those other social determinants of health that are not going directly into healthcare affect the health. Now, how is this sustainability? How are these other social determinants of health coming in? Thank you. I don't want to go very far.
Thank you for those excellent questions. And have we got one more, or are we going to wrap up? Yes, I can see one hand. Thank you.
Yes, it's not a question, but a comment. My name is Professor Laurent Musango. I'm from Rwanda, but now I'm the WHO representative in Madagascar. Well, I decided to comment on sustainability because I am within the one who started the health insurance in this country. And the question that time was how things will be sustainable when we started 3 pilot districts, Byumba, Kabwai, Kabutare, from those who know this country. And the head of state said, look, I am not the head of state of 3 districts. I am the head of state for all Rwandese. So we have to expand in all countries. Then, all questions I used to receive in conference like that one was sustainability. But I said, look, sustainability, when things are going well, politicians can take it, partners can take it, government will take it, to you, anyone will take it when we have success. So for me, as a health economist, a senior health economist, health sustainability, it's not at all an issue when things are going well. This is my conclusion. Thank you.
Thank you very much. I think that was an excellent comment right at the end on the importance actually of political leadership in all of this process. And I think maybe you want to talk a little bit about, anyone can respond to this on the question before that on retaining trust in the schemes and retaining belief in that the providers will be paid and so on. Maybe anyone wants to give some closing remarks. Yes.
Great, thank you so much. I think this statement by the Prof that really sustainability has to be born from success. Once we are successful in demonstrating that this actually works, the buy-in becomes very easy. And I think the political space wants things that actually work, that adds value to their politics, but importantly to the people they serve. And I think these pilots are driving that agenda. But ultimately, it is the role of the state. That is our primary argument, that the role of the state comes in around sustainability. The question around informal sector extension in Kenya and the sustainability of the fund. Indeed, the informal sector is always the biggest challenge because you cannot get the contributions from source. So they have to self-select into the scheme, self-register, and then be self-compliant. And that tends to bring adverse selection, that people only select into the scheme when they are sick and require access to healthcare services. But I think there are other ways in which you can motivate that. And for us, we're looking at a very strong social marketing approach, but also making it difficult and expensive to pay out of pocket. So if it's expensive to pay out of pocket, then you're creating a positive incentive to self-register and be compliant with your contributions. Again, beyond the political will and support, the sustainability of the scheme relies on a good and healthy population. That means that you have to invest in primary health care. Now, I always joke that if you look at our systems and our budgets, we basically don't have health systems, we have sickness systems, in that we prioritize sickness. And I think our funds are sickness funds. If you look at the history, these are sickness funds that really they interact with the people when they are sick, right? But I think the future has to focus on primary healthcare services. So the sustainability has to mean that even insurance schemes have an interest in investing in primary healthcare services. The intelligence that you get from your expenditure collections tells you the seasonality and patterns of disease claims. And that means that you can invest in primary healthcare to curb the claims that will come in the future. Thank you.
Thank you very much. And I think with that, you're the panelists. We've got one more closing.
You asked about the actuarial analysis.
Yes.
So the results that we also came out with, they are similar. It's somewhere around that between $2.0 and $2.5 a month from Nigeria. Now, the benefit package, that's for the benefit package that is robust, which the public servants and all of those people are using. So anything less will mean that maybe services are not available, are restricted somewhere, or the benefits are reduced. And that's what we're seeing. Some of the people who are thinking now and thinking, what would they do in their own local area? That's the challenge they are having. So hopefully we'll work around these things as we go forward. And I think, we shouldn't be scared. And I like that the remark that he made. We shouldn't be scared. We should work towards creating value. Many ways of targeting people. Once you find somebody who is on TB, it's complicated. You have found the poor. Get him on board. This pilots and whatever funds that come from government, Nigeria side it's been expanding. There's BSCP, a vulnerable group fund, the additional resources. It's just been expanding. Once people taste it, it's likely to, over time, we'll now be checking how much, to what extent are people renewing, even those in the informal sector. Are they renewing if their problems are being dealt with? Even if that problem is malaria, they are likely to stay on. And then maybe they're the ones that will take it on, like what we see in a few other places as well. Thank you.
Perfect. Thank you, Dr. Chima. And a big hand for all of our panelists there. You're released now after the panel session. So thank you. And back to our moderator for the whole. Natila's actually great. Natila's going to close us out apparently now for the whole session.
Okay. So for me, I would just very quickly answer to a couple of questions addressed to Global Fund, and then I will close. So for us, first of all, whatever pilot we have supported, it has come from a country. So we just provide the funding, but it is a country initiative, and there are country parameters there. So if we speak about vulnerable populations that we support, these people are identified by the country, so the country uses their social registers. And then, of course, the idea is, even if we speak about beneficiaries of interest groups, they should be among the vulnerable, the poor, and having the condition. So we are not pushing to fund for people just because they have the condition, but they can pay themselves. So this is number one. Number two, it will be a very long process because the schemes are very new. And I do agree with everybody here that, you know, in order for the schemes to be to be successful and to be viable, and for people to keep staying, you need to have the trust that once the money is paid, the money will go to the provider, number one, and then number two, that the quality of services offered is good. Because if people see value in the services and they see the services being provided, they will find a way, because nobody wants to pay out of pocket, you know, especially if the premiums are so small. Now, for us as Global Fund, how we see sustainability and for our end game. So, I mean, to the extent that I'm putting all my cards in the table, it is exactly that the idea, as everybody here that gets money from the Global Fund knows, we do have a co-financing policy. So I'm paying for these people, maybe for one cycle, maybe for a second cycle. And then I do have mechanisms in place to ask the government to take over some of these people in order for them to have access to the entirety of funding that they get from us. So for us is one, to build the scheme, one, to build the interest group, to have an idea of the costs that they might impose in the system. And then as the country graduates and as the country can take more on and on and on, this will be a Global Fund intervention that would need co-financing. So that is how we then work with the government to take over these people. And then for us, the end game, how I see it. I mean, the end game would be that if the insurance is the main financing scheme in the country, I just pay the insurance and they do the rest. So that would be the end game for me. I don't need to have, you know, international NGOs. I don't need to give money to providers. I don't need to give money to 15 organizations. I just give money to the insurance, and the insurance buys the medicines, insurance provides the services, insurance can contract also community organizations, civil society organizations, in case they are deemed essential for adherence, for better outcomes for people. But as I said, this is a little bit in the future, and that's why we need to start small. We need to have the trust that people are getting their services so that then we can build more and invest more. And as we invest more, we don't invest only on our people. I mean, I was there when we worked with our Nigerian colleagues, but we said that we will invest also on advocacy so that people know that this insurance exists. We said that we are keen to invest also in the facilities where people living with HIV get the services so that then they can come to a standard that they can be accredited. So it is not just like paying the premiums, it is also with everything that comes with the premiums and building the system that our help works. So now in closing, it is very exciting. We are starting small, but we are starting sure. And I am also, first of all, as somebody that started these things 3 years ago, really very excited of where we have gotten. And I think for all of you that are here, colleagues are here, they can be with you. This will be a long process, but please do consider it Kenya. Please do consider it in your country. I have been involved in and out in Kenya with HIV, being part of benefits packages, not being part of benefits packages, doing 3 rounds of actuarial analysis since 2017 at least. you know, we need you to come to Global Fund to ask for pilots that are the same as the other countries have done. So we are here, you will hear from us, we will make sure to have this exchange, but please bear in mind, let's start somewhere, let's start small, and then let's scale up. End game is everything, every international help goes to one funder or one purchaser of services in the country because this is the most efficient way. So with this, I declare the session finished.